Hello everyone. Welcome to Gynae Wizard. Today we'll begin with the first case discussion, that is antenatal case discussion. We all have to know about the antenatal case. Before going and dealing with any other case in obstetric practice. It is not only important for your exam point of view. Obviously, you will be presenting an OBS case during your exam. It is not only important with respect to your theory and practical exams as well, but it is important for you to know basic concepts of antenatal care as a clinician. Today the class will be very basic. We will cover all the aspects of antenatal care, but also it is very important that it lays a foundation to understand all other cases which we'll be discussing as a part of course in the later days. Before we go to the case proper. Today, what is the agenda? Firstly, we have to know how to present an antenatal case. What are the history we have to ask? What is the examination we have to do? What are the relevant investigations about each gestational age? And also, what are the advices which you will give in the preconceptional period, in the antenatal period, and in the postnatal period? I will be discussing all these in detail. If you have any doubts, you can ask me at the end, or we can clear your doubts on a one-to-one basis on the WhatsApp channel. Okay, without further ado, we shall start the case discussion. Firstly, in any case, we have to know the importance of the socio-demographic factors. Firstly, in any pregnant mother, whenever you approach a case or you approach a pregnant mother with a relevant history, what is important for us is to ask their socio-demographic data. What are the important socio-demographic data? These are the name. What is the importance of name in obstetrics? There are three important things to remember with respect to name. Firstly, identification of the patient. If you want to identify a pregnant woman or a pregnant mother, or if she's admitted to your ward with some complaints, you have to identify her and document the same thing in the case sheet or the OPD card. That is why name is important. The first importance of name is identification of the patient. The second important thing is the documentation of the same thing for future purposes. And the third important thing is to build a rapport between the clinician and the pregnant mother. If you call her by her name, she will feel more happy and she will be more compliant to whatever care and advice you're giving. And she will be able to share all her problems freely with you. These are the three important things with respect to name. Firstly, to identify the patient, to document the same thing, and to create a rapport between the clinician and the pregnant mother. Next important socio-demographic factor is the age. Age of the pregnant mother is very important. Why is it important? Because in the teenage pregnancies or in the elderly pregnancies, the chances of obstetric complication is slightly higher than compared to the age group of 20 to 35. 20 to 35, we usually tell that it is slightly safe for pregnancy, while as less than 20 years is considered as teenage pregnancies and more than 35 years are considered as elderly pregnancies. What is teenage pregnancies? Whenever there are teenage pregnancies, the reproductive tract is not well developed to carry the pregnancy. Sometimes it might end up in miscarriages. The chances of preeclampsia and hypertensive disorders of pregnancy is high. And even the chances of congenital anomalies might also be there. And there might be anemia, especially in India, which is the anemic capital. There might be significant anemia if she is not prepared for pregnancy. All these are the complications which occur in the antepartum period. And whereas she might go into preterm labor, and sometimes chances of instrumental delivery and cesarean section are slightly high. And also postnatally, she will not be able to manage the baby as she is not mature enough to take care of herself and the baby. Even mentally, physically, and emotionally, she is a slightly younger age group which cannot manage all these independently. So that is why teenage pregnancies and elderly pregnancies are considered to be risk factors. And whenever you classify the risk of pregnancy, if she belongs to the age group of less than 20, we tell that it is a high risk pregnancy and requires a close vigilance. And also, on the other hand of the spectrum, there is elderly pregnancy. So, whenever the maternal age is more than 35 years and she's getting pregnant for the first time, then you consider to be it as elderly primigravida. So, what are the complications of elderly primi? So, usually, elderly primigravidas are associated with congenital anomalies, especially if it is something like aneuploidies, like Down syndrome, Turner syndrome, or Patau syndrome, or sometimes there might be having coexistent chronic disorders like diabetes, hypertension, or thyroid disorders, which might also have their implications on pregnancy, and also the chances of obesity and related complications, and also the other chances of prolonged labor, macrosomia, and sometimes leading to instrumental delivery, cesarean section, failed lactation, deep vein thrombosis. All these are significant complications which might occur in elderly pregnancies. So that is why maternal age is very much important. And there we have to classify the risk as high risk. So risk stratification is a very important principle of antenatal care. The next important thing we have to move is to education, occupation, and socioeconomic status. So we all know that education, occupation, and socioeconomic status, they go hand in hand. So if the patient or if the pregnant mother, so it is always better to address the woman as a pregnant mother rather than a patient, because pregnancy is a physiological process. So it is always better for us to address as pregnant mother or a pregnant woman rather than a pregnant patient or a obstetric patient or a case. So it is better we tell it as pregnant mother. So if she is educated well, she will be having an occupation and a good socioeconomic status. So she will be compliant to your advice. So whatever advices in terms of diet, nourishment, and lifestyle you're asking her to follow, she will be able to follow. And also, if you explain her certain risks and complications during pregnancy, she will understand better and communicate better, and she will be able to come to the hospital when needed immediately. So that is why all these go hand in hand. But as a postgraduate, what is it important for you to know is about the socioeconomic status. So you all know in different obstetrics or medicine or pediatrics, there are different classifications which are available for socioeconomic status. But for us, it is important to know about two important classifications. So one is the BG Prasad classification, which is usually applicable to the rural population. And the second important classification is Kuppuswami's classification. So this is usually used for urban population. So whenever the woman is coming from the rural population, you will use a classification called as BG Prasad classification, and Kuppuswami is usually used for urban population. So what is BG Prasad classification? It is mainly dependent on per capita income of the family. So if there are four people in the family, and if the total income of the family is around 10,000, so 10,000 divided by 4 is the per capita income. So based on this, we will divide the classification, we will divide their risk, or the different types of classification is, there are 5 types. So the first one is the upper class. The second one is the upper middle class. The third one is middle class. Then we have lower middle class and we have lower class. So upper class, upper middle, lower middle, and lower. These are the 5 classes in BG Prasad classification. It is mainly based on only per capita income. So according to the recent 2024 guideline, the per capita income is around 9,000, more than 9,000 is upper class, around 4.5, 4.7 to 9,000 is upper middle, and around 2 to 4.5 is middle. 1.3 to 2 is lower middle, and less than 1.3 is considered to be lower. So this is, you can refer it from Google or your PSM textbooks. This is the recent updated the version of BG Prasad classification. Next, coming to Kuppuswami's classification. So this is dependent on three parameters. So the first one is the occupation of the head of the family. Next, there is education of the head of the family and the total monthly income of the family. And this is given different scores. So again, here we have five categories. So this is upper middle, lower middle, upper lower, and lower. So these are the five categories which are present in the Kuppuswami's classification. So to keep it simple, what a postgraduate must know during their exams or how to answer during exams is simple. So this woman belongs to the upper class of socioeconomic status. If you tell according to Kuppuswami, if they ask you about it, you can tell that it is based on three parameters. One is the occupation of the head of the family, education of the head of the family, and the total monthly income of the uh, entire family. It is not per capita income, it is the total monthly income of the family. So it is divided into upper middle, lower middle, upper lower, and lower class. So this is very important. And we have to know about socioeconomic status. So this importance is I've already discussed. The next important socio-demographic factor which we are interested is the address of the pregnant woman. So usually in medicine or surgery, we tell that this is mainly important to see the endemicity of diseases in different populations. So for example, this belt of Haryana, Mumbai, all these are more common and they have more common in hemoglobinopathies. And whenever there is high altitude areas, it is more common for iodine deficiency and goiter. So these endemic regions are common. But what as an physician we have to know about address. This is also, endemicity is also important, but along with that, we have to assess what is the distance of the woman to the hospital. So where is the nearest health facility for the woman? So if you are advising her that if you have any imminent symptoms of preeclampsia, so if she has headache or blurring of vision or any visual disturbances, if you ask her to check her BP, uh, whether she is near to the healthcare facility or not must be important. She's a case of placenta previa. So she would have come to you with an episode of warning hemorrhage. So you will tell, okay, if you have another episode of warning hemorrhage, you have to immediately revert to the healthcare facility. So that time you have to assess the distance between the hospital to her residing place. And sometimes if she's come with false labor pain, you have to see the distance of the hospital to the healthcare facility. So to decide whether she needs an inpatient admission or it is very near where she can travel immediately to the near healthcare facility and seek her medical care. So that is why address is very important. And also, along with the address, you have to also mention her near by healthcare facility. So whether a PHC is nearby her or a CHC or a district hospital or a tertiary care hospital or it is very near to our medical college. So anything like that must be discussed with her and it has to be written in her antenatal card priorly. The next important information we have to gather is the date of admission. So why date of admission and date of examination are important? Because whenever the woman gets admitted to the hospital and then you're examining her on a different day. For example, today she's come with palpitations or easy fatigability. After 4 to 5 days, you have examined her. So that time you will ask her chief complaint. She tells that I had come with easy fatigability, but now I'm comfortable. So what is important here is the date of admission and date of examination. So if she's a case of anemia and you have already treated her with blood transfusions or iron infusions and she's stable now, the treatment history is very important. So what treatment was given in the healthcare facility has to also be elicited in the history taking. So that is when the date of admission and date of examination holds its importance. So the next coming the characteristics of last menstrual period. So what is last menstrual period? It's the first day of last menstrual period. So the first day of last menstrual period is LMP, and then we compute the expected date of delivery by Negley's formula. So what is Negley's formula? You will add 7 days plus 9 months to her last menstrual period, and then you will compute her expected date of delivery. And today, what is her gestational age must be calculated, and this gestational age assessment has to be done to categorize whether the woman belongs to first trimester, second trimester, or third trimester. So if it is first trimester, according to the PG books, less than 14 weeks is considered as first trimester, 14 to 28 weeks is considered as second trimester, and more than 28 weeks, and the EDD falls on the 40 completed weeks. But what if it is an IVF conception? So it depends upon the number of days of hormonal preparation before you do a embryo transfer. So whenever there is an IVF patient who is conceived out of an embryo transfer, that time you have to take the date of embryo transfer, date of ET, that is embryo transfer, plus 266 days. So 266 days will give her expected date of delivery, that is corresponding to 40 weeks of gestation. So in a routine, now pregnant woman who is conceived naturally or with OI or IUI, you take the LMP, add 7 days, then add 9 months to get the expected date of delivery according to Negley's rule. But if she is underwent an embryo transfer as a part of in vitro fertilization, you have to add 266 days, because 280 days is the total duration of pregnancy. So these are the three important things you have to also mention in your first slide, or when you're presenting the case. LMP, EDD, and gestational age has to be mentioned. One second. So whenever you're finished with the socio-demographic factor, what are the next important things you have to ask? So the next important thing before chief complaints is to ask her about the parity. So what is parity? Parity is nothing but the obstetric score which must be written at the starting of the case. So whenever you finish, so for example, you start presenting a case and you will be like, I'm presenting a case of Mrs. Veena, age 20 years, who's residing from some nearby place, and she's studied up to 10th standard of lower middle class according to BG Prasad classification. So after all this, she was date of admission and date of examination will be told, and immediately then you will speak about parity. So before you go into chief complaints, you have to mention the obstetric score. So for example, if she is gravida 2, para 1, living 1, with so and so months of amenorrhea. So with 9 months of amenorrhea. So this gravida, para, living, death, abortions, and in abortions, if it is either an ectopic or molar pregnancy, has to be mentioned the starting itself. So you all, as it's an undergraduate thing, to know all the definitions of gravida, para, living, abortions, and in abortions there are different types of abortions. And if it is an ectopic pregnancy, so if it is A2, if there was one ectopic pregnancy with one molar pregnancy, you can write it as bracket. So but they fall under abortion category. But if you want me to tell what is the definition of gravida, so sometimes some examiners can go into very basic things. So as a postgraduate, you must know. It is like a must know thing that you have to know all the definitions of this obstetric index. So definition has to be told as a definition. So what is gravida? It is the total number of conceptions, including the present pregnancy, irrespective of the period of gestation. So that is gravida. So you have to speak about the definitions like a definition. So then she comes with 9 months of amenorrhea. And whenever you talk about a woman in her second or third trimester, that is past her 20 weeks of gestation, perception of fetal movements carry a very high importance. So why is perception of fetal movements important? One second. Sorry. So why is perception of fetal movements important? So firstly, we have to know that the fetus is viable and whether she's perceiving fetal movements well. And it's the utmost important thing you have to ask past mid gestation, that is after 20 weeks of gestation. So immediately after you ask about the perception of fetal movements, then you have to ask her about her chief complaint. So once you present the socio-demographic factors, then you can directly tell she's a gravida to para 1 living on with 9 months of amenorrhea. She's perceiving her fetal movements well, and now she's come with chief complaints of pain abdomen since 2 to 3 hours or pain abdomen from yesterday night. So you have to not include this obstetric score, months of amenorrhea in your chief complaints. So don't put the heading as chief complaints and then write gravida to be, because obstetric score and the months of amenorrhea are not her chief complaints. They are the things which has to be mentioned prior to chief complaints. For example, if she does not have any chief complaint, she's come just for delivery or she's just come for an antenatal checkup, you can write gravida to para 1 living one with 9 months of amenorrhea who's perceiving fetal movements well, has come to OPD for an antenatal checkup or has come for admission for an now has come for admission for safe confinement. So these words can be used instead of mentioning it as chief complaints. But the chief complaints are very important and they have to be mentioned in the chronological order. As in any cases in final year, you have to mention the chief complaints in chronological order. For example, if she has pain abdomen and leaking PV, so which was first? So she has leaking PV since yesterday night around 12 a.m., but she has pain abdomen since morning 6 a.m. So that means she has PROM and spontaneously she's gone into labor if she's gone into labor, and those are true labor pain. So that is how chief complaints helps us to understand which came first, and it has to always be written in the chronological order. So next, coming to the history of presenting illness. So what is important in history of presenting illness? We have to elaborate the chief complaints. So what, for example, if she's come with pain abdomen, so you have to tell she had pain abdomen, insidious in onset, gradually progressive, localized to the lower abdomen. If is it intermittent or continuous? Is it dull aching? Is it radiating? What are the aggravating factors? What are the relieving factors? So all these are important with respect to the chief complaints and whatever symptom she's come with. So if it is associated with leaking PV or whether it is associated with bleeding PV, all this has to be elaborated in detail. So for example, I want to give you a small example. For example, she's come around 9 months of amenorrhea, she's perceiving fetal movements, and you have asked her what are her chief complaints. She will tell, I have pain abdomen. So what is the next important thing you will ask? So you will ask whether it is to differentiate between true labor pain and false labor pain. You will ask her what are the aggravating factors. Okay, what is the insidious, whether it is insidious in onset, whether it is continuous or intermittent, whether it is dull aching, and whether it is associated with the increasing in intensity, duration, and frequency, and whether she has any other symptoms like cervical show. So what is show? It is just the dislodged mucus plug which is admixed with the blood, discharged mucus plug which is admixed with blood, which is mainly due to friable capillaries at the level of cervix because of the cervical changes which occur with respect to true labor pain, and it does not relieve on rest, sleep, or giving enema or any other drugs. So these are the important characteristics of true labor pain. So whenever she comes with pain abdomen, it is not only the labor pain which has to be asked about. You have to also ask about other negative history. So why other negative history is important? Because you have to know whether it is true labor pain, false labor pain. But if there is continuous pain abdomen with decreased frequency of decreased perception of fetal movements, and also she tells that it is accompanied by bleeding PV, you have to also rule out abruption in term gestation. And sometimes if it is a previous LSES case, you have to rule out uterine rupture. So these are all important differential diagnosis of pain abdomen in the third trimester. And these are the causes, obstetric causes of pain abdomen. So what about the gynecological causes of pain abdomen? Red degeneration of fibroid or the torsion of ovarian cyst. So these are the gynecological causes of pain abdomen. And what are the surgical causes of pain abdomen? All itis, cholecystitis, pancreatitis, and gastritis. So all these are differential, appendicitis. So all these are differential diagnosis of pain abdomen, and these go in favor of surgical causes. So what are the medical causes? If she has any urinary tract infection, whether she has any pyelonephritis, or whether she has any colitis, so whether she has any IBD. So all these are medical causes of pain abdomen during third trimester. So whenever you're describing about pain abdomen, you have to always go in favor of what is contributing to your diagnosis. So for example, if she's coming with true labor pain, you need not mention about increased frequency of micturition or burning micturition, because UTI will not present to you like labor pain. There will be diffuse lower abdominal pain, which is continuous and it is associated with burning micturition. So you need not write no history of burning micturition, because she already has come with corrective characteristics of true labor pain. So always you have to elaborate the chief complaints, and the relevant negative history has to be asked. You should not ask everything. So it is not that you are asking all obstetric causes, all gynecological causes, you have to not ask. So what are the relevant negative history for that particular chief complaint has to be detailedly written, and so that we will go into a provisional diagnosis and will be able to manage the womb accordingly. So till now, we have understood the importance of socio-demographic factors, and we have to mention the parity, the number of months of amenorrhea, perception of fetal movements, and the chief complaints. And according to the chief complaints, which are written in chronological order, we have to elaborate the chief complaints with respect to history of presenting illness, and along with that, the relevant negative history has to be highlighted, so that we can go into a probable differential diagnosis and arrive at a provisional diagnosis. So that is about history of presenting illness. So I will unmute you people. So if you have any doubts till now, you can ask me. So any doubts till now? You can unmute yourself and ask
No,
if you
ma'am,
have
it
any
is clear.
doubts. Otherwise, we can continue. Any doubts? Okay. So I hope there are no doubts. We'll get back to the doubts after some time if you have any, or at the end of the session. So next, before we move into the obstetric history, what is important with respect to sorry, what is important with respect to antenatal care? So, as a postgraduate or a clinician, what is antenatal care? So, it is a systematic approach or supervision of the pregnant mother during her pregnancy. So, which is either called as antenatal care or prenatal care. So, you have to know as a postgraduate certain theoretical aspects of antenatal care. So, what are the theoretical theoretical aspects of antenatal care, you have to know the definition of antenatal care. So it is given by ACOG. And what are the objectives of antenatal care? What are the aims of antenatal care? So the definition, which is usually given in Datta, is slightly simple. So that is a systematic supervision of the pregnant mother during pregnancy is called as antenatal care or prenatal care. But I will tell you what is the definition which is given by ACOG. So I wanted to be precise, so I will read it out. So ACOG, it defines antenatal care as a comprehensive antepartum care program that involves a coordinated approach to medical care and psychosocial help that optimally begins before conception, extends throughout the antepartum period. So, what does it include? It includes the preconceptional care of the woman. It includes prompt diagnosis of pregnancy, and the important objectives and aims have to be satisfied as a part of prenatal care, and also the follow prenatal visits have to be scheduled. So all these are the things which have been highlighted by ACOG. And next, very important is the objectives of antenatal care. So what are the different objectives? So the first important aims and objectives of the antenatal care is to stratify the risk of the pregnant woman. So I will be sharing you the Foxy guidelines. So they have clearly told that there are certain risk criteria during the present pregnancy or during the past pregnancy, which categorizes the woman to be a low risk category or a high risk category. So this is very important. So as we already discussed, teenage pregnancies, elderly pregnancies belong to a high risk category. So this risk stratification is very important for us to understand. Why? Because we have to diligently tell the woman her follow-up visits, and the high-risk case needs a more and more of attention when compared to a low-risk pregnancy. So this is the first important aim and objective of antenatal care, that is risk stratification. The second thing is identification and treatment of pregnancy unique complications. So what are the pregnancy unique complications? Preeclampsia, gestational diabetes mellitus, hypothyroidism during her pregnancy, anemia in pregnancy, or if she has any placenta previa. So you have to identify these pregnancy related complications which are unique during pregnancy, and you have to manage them appropriately. And the third important thing is to ensure whether she has any other pre-pregnancy complications. So if she's already a case of diabetes mellitus or a chronic hypertension, or she has obesity, so to identify any pre-pregnancy complications and to manage pregnancy in them. So that is the third objective. The fourth important thing is health education and health promotion. So you have to educate the woman about what are the investigations she has to get it done during the respective trimester, what are the supplements she has to take, and also you have to counsel her about the mode of delivery, you have to counsel her about breastfeeding, you have to counsel her about postnatal care, and also counsel about immunization and contraception in the postnatal period. So health education and health promotion both go hand in hand, and all these five or six aims and objectives are very important with respect to antenatal care. So this is given in your basic books like Datta or Williams. These antenatal care aims and objectives have been highlighted, and these might be asked in your exam. So they can suddenly ask, what is the definition of antenatal care? So that time you cannot tell something in your own language. The definition has to be reflected from the textbook or the guideline. So these are the important theoretical aspects which you have to know. Okay, so next we'll continue. So what are the other things we have to know? So next is a very important is the obstetric history. So under obstetric history, marital life. So how many years they are married for? So in the obstetric history, the first important thing is the married life of the couple. So if they are married for 15 years or 10 years, so before we used to use a term called as precious pregnancy, but nowadays we do not use that term because every pregnancy is considered to be precious. So don't use such terminologies in present scenario. So we just try to understand whether the couple has conceived after a long period of marital life, that is active marital life, or it is a normal pregnancy where they immediately spontaneously conceived. So that is very important. The second very important thing in obstetric history is the consanguinity. So there are different degrees of consanguinity. So it's first degree consanguineous marriage, second degree consanguineous marriage, and third degree consanguineous marriage. So what is first degree consanguineous marriage? When they are marrying siblings. So it is very rare in Indian population. So marrying siblings is called the first degree. Marrying the maternal uncle is second degree. And the first cousin, either aunt son or uncle's son, first cousin is the third degree consanguineous marriage. So first and second degree are associated with high risk of chromosomal aneuploidies or abnormalities. So whenever there is marriage in between the relatives, the chances of expression of recessive genes is more common. So that is why whenever they are married out of a consanguineous marriage, we have to do a proper prenatal screening and diagnosis to rule out chromosomal abnormalities. So the chances is very less, as less than 0.25 to 1%, but you have to explain them the risk and you have to carry forward the antenatal care. So that is the importance of consanguineous marriage. And next, as we already have told about obstetric score, so gravida. So whenever you present in exams, don't tell G2 P1 L1 or G3 P2 L1 D1. So don't tell like that. You tell gravida 2 para 1 living 1. So it has a better it it holds a better view when compared to telling G2, P2 and all. So if you use the term gravida, it is better. So when you're presenting in exams also, elaborately use gravida, para, living or prime. If it is the first time, if she's getting pregnant, you can use a term primi gravida. So obstetric score is very important and it has to be written in detail. So I hope I need not explain you what is gravida, para, living, abortions. So as a postgraduate, you will be well aware of it. Next, coming to obstetric history, that is past obstetric history. So many of the students have this doubt. So they want to write first elaborate about this pregnancy and then about the past pregnancy. No, always we have to speak about the previous pregnancies before we go to the present pregnancy details. So why previous pregnancy is important? Because the management of present pregnancy is entirely dependent on the course of previous pregnancy. For example, if she's a previous case of gestational diabetes mellitus, the chances and risk of gestational diabetes mellitus during the present pregnancy is also high. For example, she had a previous cesarean section. So that time you have to think whether you want to give a trial of labor after cesarean section or you want to directly go for an elective repeat cesarean section. So all these depend on the previous obstetric history. For example, she had 3 first trimester abortions. Now you're very much keen. What is the reason for first trimester abortion? You have to evaluate and manage the present pregnancy so that that might not lead to an abortion. So that is why we have to be very much vigilant in knowing about her past obstetric history before we go into detail about the present obstetric history. So what is important in the past obstetric history? It is not only what baby was born. So some postgraduates write, gravida 2, para 1, living 1, P1 details. So male baby, previous LSCS, 3 kgs at birth. The birth weight was 3 kgs, 3 years back, alive and healthy. So this is not the way a postgraduate has to write the past obstetric history. So past obstetric history, what are the important things you have to write? So what are the important things? The first important thing is what type of conception. So whether it was a spontaneous conception or an induced conception, or whether she had an IUI or an IVF, whether it was a embryo transfer which was done. So all these we have to write. And the second important thing is the antenatal period. So whether the antenatal period was eventful or uneventful in the previous pregnancy. And then you have to write about intrapartum. So what about intrapartum? Whether she went into spontaneous labor or whether she had an induced labor or whether she had a prolonged labor, then she was taken up for second stage cesarean section, or she had an instrumental delivery. So all these things, so the duration of for the labor, whether it was spontaneously setting into labor or whether there was induction with any pharmacological induction or mechanical induction, all these you have to ask. So nowadays women are very, so they have one or two childbirths. So they know in detail about their pregnancy. So previously they used to deliver at home. They used to not have much idea about their births. But nowadays the women give each and every detail about their previous pregnancy. The only lacking thing is we asking them about her previous pregnancy. So you have to ask when it was, when she conceived, how many years after her marriage, then immediately now, how was her antenatal period? Whether she had any antenatal complications like anemia or hypothyroidism or whatever it might be. And then the intrapartum. And next, in intrapartum only, you will tell about the baby details. So she delivered a live baby, live male baby of birth weight 3 kg, and it was a vaginal delivery. And the baby is presently 3 years of age, and the baby was breastfed for 1 year, and the immunization was up to date, and the present the baby is alive and healthy. So all these postnatal information also you will give. And if she's a case of previous LSCS, any wound related complications, any blood transfusion, what is the duration of stay in the hospital, or if it is a preterm delivery, if the baby is admitted to the NICU, whether the baby was on ventilator or whether it was on room air, whether the baby stayed for how many days in the NICU, all these hold importance. So, because if it is a previous cesarean and it was a preterm cesarean section, obviously this pregnancy, the chance of uterine rupture is slightly high, because in previous sections done for preterm, in preterm cases, sometimes the scar would not have been healed well. So this time the chance of uterine dehiscence, scar dehiscence or uterine rupture is slightly high. So you might not, you might consider giving her elective repeat cesarean section or a TOLAC, you will based on other maternal characteristics. So all these are important, and that is why I mentioned and I'm highlighting that the management of the present pregnancy is always dependent on the previous pregnancy. So, or one take home point for today is always mention the past obstetric history in detail. I'm not telling you to write trimesters. For past obstetric history, you need not write first trimester, second trimester, third trimester. You need not write. At least write the important details of her past obstetric history. For example, if it was an abortion, so write whether it was a spontaneous abortion, whether it was an MTP which was done because of any neural tube defects or any congenital heart diseases or any other problems, or whether an MTP was done for a social cause. What was the gestational age during MTP? Whether it was a first trimester abortion, whether it was a second trimester abortion, whether there was any hysterotomy, or whether it was a molar pregnancy, whether it was an ectopic pregnancy. So all these details has to be asked, and so that it might have some reflection during her present pregnancy. So these things have to be highlighted in her past obstetric history. So next important thing is the history of presenting pregnancy. So what is the importance of history of presenting pregnancy? So present pregnancy, you have to ask trimester history. So what you have to ask in the first trimester, what you have to ask in the second trimester, and what is the importance of third trimester. So firstly, as I told you, in the first trimester, you have to mention about the type of conception. So whether it was a spontaneous conception, whether she has taken any ovulation induction drugs, which was accompanied by natural cycle, that is timed intercourse, or intrauterine insemination, or whether IVF was done, whether it was the first cycle or second cycle, or which cycle of IVF it was positive. So what is the type of conception is very important. The next important thing is the UPT. So what is UPT? Urine pregnancy test. So usually we ask the woman when the urine pregnancy test was done. So now all educated women do a UPT at home. So she might tell, I missed my period. So 1 week after my missed period, I did a UPT. It was positive. So I came to the hospital. So always when you mention about the UPT, you have to tell pregnancy was diagnosed, or she did her UPT at 1.5 months of amenorrhea and it was said to be positive. So you can either tell UPT was done and it was positive, Or you can either tell UPT was done and pregnancy was diagnosed. Never use the word confirmed with respect to UPT. So, urine pregnancy test can only diagnose pregnancy, but confirmation is always with the ultrasound parameters. Why? Because there is something called as biochemical pregnancy loss. So, what is biochemical pregnancy loss? Urine pregnancy test might be positive. Beta HCG value might be more than 50. But when you do a scan, if there is no evidence of intrauterine or extrauterine gestation, then it is definitely you cannot confirm the pregnancy. And sometimes she will tell, I did my UPT after my missed period, but then after 4 days I had bleeding PV, and then I checked with the doctor, and the doctor told that there is no pregnancy anymore, and they called it as biochemical pregnancy loss. So, what is biochemical pregnancy loss? There is no evidence, ultrasound evidence, or confirmatory evidence of pregnancy. Though biochemical parameters were said to be positive, there was no confirmatory evidence of pregnancy. Whether it is intrauterine or extrauterine, there is no gestational sac which is seen on ultrasound to confirm the pregnancy. So that is why UPT was done. It was said to be positive at 1.5 months of amenorrhea, or it was done at home and said to be positive at 1.5 months of amenorrhea, or UPT was done and pregnancy was diagnosed. So all of these can be used. So once you tell that UPT was done and pregnancy was said to be positive, immediately you can tell that it was confirmed by ultrasound examination. So how do you confirm pregnancy by ultrasound examination? So usually it depends upon the beta HCG values. And in UPT also, so there are different methods which we can diagnose pregnancy. So usually in pregnancy, what happens? There is increase in beta HCG. So human chorionic gonadotropin protein is increased and it is secreted actively by syncytial trophoblast of the placenta. So this beta HCG is detected both in the blood and urine. So it is feasible to do a urine pregnancy. So you in clinical practice, we do a urine pregnancy test, and if it is positive, then we see the weeks of gestation and then plan for ultrasound. So what are the different tests which are available? So there is something called as direct agglutination assay, indirect agglutination assay, ELISA, and radio immunoassay, fluorescent immunoassay. So there are many methods. So based on the level of beta HCG and the test criteria of beta HCG, and also the number of days after the fertilization, the detection rate of the test is dependent on what test you are performing. So usually we do a card test, which is the sandwich ELISA method. So there will be the antibody will be present in the card. The antigen, that is the beta HCG, will be present in the urine. And whenever there is antigen antibody reaction, there will be a color coded monoclonal antibody which gets attached to it, and there will be two lines on the beta HCG card, sorry, UPT card. So if there is two lines, one is the control line and one is the test line. So if there is two lines, it is said to be positive. If it is a single line, it is said to be negative. If there is no line, then the test card test is defective and you have to repeat her urine pregnancy test. And so beta HCG, if it is bit more than 25 to 50 milli international unit per ml, it is said to be that the woman is pregnant. So if it is less than 15, then it is said to be negative. So that is about beta HCG. So go and read in detail about all the tests, and this is also given in your basic books. Even Datta has given a beautiful table which elicits the level of beta HCG for the test to be positive, and also the number of days from conception for the test result to be positive. So next, as I told you, once UPT is done, you have to definitely do an ultrasound examination. So the first trimester ultrasound, preferably, which is done between 9 to 11 weeks, ideally. So 9 to 11 weeks, it should be done to date the pregnancy. So what is the importance of first trimester ultrasound. So you have to always do a first trimester ultrasound. As I told you, it confirms the pregnancy. So when do you want to do a first trimester ultrasound? So whenever the beta HCG value is more than 1500, you can visualize the gestational sac on the transvaginal sonography. So this is called as the discriminatory zone of beta HCG. So if the value of beta HCG is more than 1500, you can do a transvaginal scan to visualize the gestational sac. But if you want to do a transabdominal sonography, then the beta HCG value should be at least 5600. So 1500 for TVS and 5600 for TAS. So this is the level of beta HCG where the gestational sac must be visible. So usually it follows an order. So firstly, there is appearance of the gestational sac, then there is appearance of the yolk sac, then there is appearance of the fetal pole, and then there is appearance of the cardiac activity. So usually the gestational sac appears around 4 weeks on a transvaginal ultrasound. Yolk sac appears around 5 to 5.5 weeks. The fetal pole is appeared by 6 weeks, and the cardiac activity is appeared by 7 weeks of gestation on a transvaginal sonography. So gestational sac, yolk sac, fetal pole, cardiac activity. So these are the series of changes which occur between 4 to 7 weeks of gestation. So what is the importance of first trimester ultrasound? So firstly, to confirm the pregnancy, and next to confirm whether it's an intrauterine pregnancy or an extrauterine pregnancy. The third important thing, to date the pregnancy. So based on the CRL, we can date the pregnancy. So how can we date the pregnancy? If the CRL is corresponding to what weeks of gestational age. So then we can know whether it is corresponding to her LMP EDD, or we have to take the ultrasound, the EDD with respect to her corrected gestational age. So how do you consider this? For example, if the scan is done for less than 7 weeks of gestation. So there is a table in Williams. So that table you have to remember. So I will read out that table in Williams for you to understand. Yeah. So less than 9 weeks of gestation, you have to take a threshold of more than 5 days discrepancy. So if, for example, LMP is uh, LMP is around September 15th. Next, her EDD is around 22 of June next year. If her ultrasound EDD is around 30th of June. So there is discrepancy between the LMP EDD and the ultrasound EDD, and this is more than 5 days. So you have to take the ultrasound EDD. So there's a table in Williams which beautifully tells the gestational age, what parameter you have to consider to date the pregnancy, and what is the threshold value of the discrepancy between the LMP expected date of delivery and the scan expected date of delivery, and when you have to take the scan expected date of delivery. So less than 9 weeks of gestation, it is less than 5 days. 9 weeks to 14 weeks, it is more than 5 days. 9 weeks to 14 weeks, more than 7 days. 14 weeks to 16 weeks, again more than 7 days. 16 weeks to 22 weeks, more than 10 days. 22 to 28 weeks, more than 14 days. More than 28 weeks, more than 21 days. So this table also I will share you on the group. So this has to be noted and it has to be important. So why? Because whenever she tells her LMP and you calculate with Negley's formula, then you will ask her first trimester ultrasound. But usually in exams, they will not give you the reports. But in your general practice as a clinician, you will ask her first trimester ultrasound. And if it is done at 8 weeks of gestation, and if the discrepancy is more than 5 days, obviously you have to take the scan expected date of delivery, and that is important. So I will write here. So less than 9 weeks, it is more than 5 days. 9 weeks to 14 weeks, more than 7 days. Again, 14 weeks to less than 16 weeks, more than 7 days. 16 weeks to 22, less than 22 weeks, more than 10 days. 22 weeks to 28 weeks, more than 14 days, and more than 28 weeks, more than 21 days. So this is how you will calculate the expected date of delivery and corrected expected date of delivery if there is the discrepancy. So this is very important. So to date the pregnancy. So first thing, confirmation of the pregnancy. Second thing, whether it's an intrauterine or extrauterine gestation. Third thing, to date the pregnancy and accurately know the expected date of delivery. The fourth thing, whether it is a single gestation or a multiple gestation. So whether there are two gestational sacs or three gestational sacs, so whether it is twins, triplets. So based on that, you will know whether it's a singleton pregnancy or a multiple pregnancy. And certain uterine anomalies can also be seen only in the first trimester ultrasound. So for example, there is a bicornuate uterus. So in the first trimester ultrasound, you can see a beautiful bicornuate uterus, and the pregnancy is in the right horn. But if she's missed her first trimester, she's directly come for anomaly at 20 weeks. What happens? The pregnant horn will enlarge and the small horn will remain a small knob-like structure which might be missed during her second trimester. So these anomalies, especially like septate uterus, bicornuate uterus, or didelphus, whatever anomalies we are talking about can be made out in the first trimester ultrasound. And also fetal anomalies, especially anencephaly, can be detected as early as 10 weeks of gestation. So fetal anomalies are also seen in the first trimester, and a basic fetal survey, anatomic fetal survey is done in the anomaly scan, but at least you can visualize the calvaria, you can visualize the brain components, you can visualize the face, NT, you can visualize the nasal bone, you can visualize the nuchal translucency. All this can be elicited in the first trimester. So along with that, the other important thing which you have to remember in first trimester ultrasound is any other uterine or adnexal masses. So if there is a fibroid, you have to identify in the first trimester ultrasound. For example, if there is a 4 centimeter fibroid, then throughout the pregnancy, you have to see where the fibroid is, whether it is in the upper segment or lower segment, whether it is near the cervix, whether it will impinge on the cervix, and sometimes it might be difficult for a vaginal delivery. So all this you have to identify. Or if there is a huge ovarian cyst, so what is the size of the cyst, whether the cyst needs removal or whether it is a small size cyst which need not be intervened during pregnancy. All this has to be seen in the first trimester ultrasound. So there are 7 important things you have to know in the first trimester ultrasound. So what are they? Firstly, to confirm the pregnancy, intrauterine or extrauterine pregnancy, the dating of the pregnancy, that is the confirmation of expected date of delivery, whether it is a singleton pregnancy or a multiple pregnancy, any uterine anomalies, any fetal anomalies, any uterine masses or adnexal masses. So all these are the very important 7 characteristics of first trimester ultrasound. So along with that, you have to also ask whether aneuploidy screening in the form of ultrasound was done. So that is nothing but the NT scan. So NT scan, now it has become mandatory between 11 weeks to 13 weeks, 6 days. So what should be the CRL for NT to be performed? It is 45 to 84 mm. So what is NT? It is nothing but nuchal translucency. So it is nothing but the fluid which is present in the nape of the neck of the fetus. So why is it important? So if the NT is more than 3 mm, so usually we take the cutoff as 3 to 3.5. Sometimes 2.5 also might require additional modalities to diagnose whether there is raised NT or not. So you have to see if the NT is raised. So when the NT will be raised, whenever there are chromosomal anomalies, whenever there is cardiac dysfunction, or whenever there is any lymphovascular system dysfunction. All these are the different situations where there is increase in the nuchal translucency. But there are many criteria to measure the nuchal translucency. So the head and the thorax must be filling most of the portion of the monitor, that is the ultrasound screen. The fetal head must be in the mid sagittal plane. You must have to be what you have to focus. The head should not be either too flexed, hyperflexed, or hyperextended, and the nasal bore and the thalami and the NT should all be seen, and intracranial translucency also has to be seen. And you have to measure the NT with respect to the inner calipers of the. So if this is the NT, you have to place the calipers on the inner surface of the fluid accumulation. So at least three measurements you have to take, and the maximum measurement of what you get, you have to measure. And if it is more than 3 mm, definitely it warrants further prenatal diagnostic tests. So if the gestational age is less than 15 weeks, you have to either go for chorionic villus sampling, or if you are going after 15 weeks, you have to go for an amniocentesis to diagnose what is the reason for increased nuchal translucency. So this is a very important concept of prenatal screening and diagnosis, which has to be done between 11 weeks to 13 weeks, 6 days. And also along with nuchal translucency, nasal bone has to also be seen, whether the nasal bone is present, what is the measurement of the nasal bone, whether there is an hypoplastic nasal bone or an absent nasal bone, which also warrants that it might be one of the risks for chromosomal aneuploidies, especially trisomy 21, that is Down's syndrome. So this is very much important to be a universal screening as a part of prenatal screening and diagnosis. So this is the importance of first trimester ultrasound. So all the 7 characteristics along with nuchal translucency and nasal bone are important with respect to the first trimester ultrasound. The next, and you have to read about why NT is increased in cases of aneuploidies or cardiac dysfunction. So you have to read about the theoretical aspects of nuchal translucency and other parameters of prenatal diagnosis. Okay, now, till now, do you people have any doubts? Am I fast? You can unmute yourself and answer. Am I fast, or do you want me to repeat something, or do you have doubts in whatever we have covered up till now? No one is ready to unmute. Okay, I will consider that you have no doubts and we can continue with the rest of the class. So next, coming to booking investigations. So in this class, I'm covering all the basic concepts. You might think that this might not be that important, or you might think why madam is telling the same things which we already know. But no, in your final exams, when you're talking about different things, you might forget the basics. So you should never forget the basics, and these form a firm foundation for all other cases. And it is not only exams, leave exams, but as a logician, once you pass out, as a clinician, you have to know the basic concepts of why USG is important, why NT is important, what are the theoretical concepts. So all these are important for you for a better understanding and learning of concepts. So that is why I am discussing utmost basic things and level of information what a postgraduate must know during her before you graduate. These are the must know things as a part of OBG post graduation. So next, coming to what are the minimum booking investigations to be done. So before this, you have to tell whether it is a booked case or not. So what do you mean by booked case? So whenever if someone asks you what is a booked case, so what is your answer? So booked case, the first important criteria is that she has to be registered in the healthcare facility. So in each state, you have different books. So here we have a health card. In Karnataka, there is something called a Stai card. So they get registered in the nearest government facility. So registration is important. The second important thing is, as a part of the national program, at least 4 antenatal visits have to be recommended. The third important criterion for a booked case is she has to take at least 100 days of iron and calcium during her pregnancy. And the last important thing is she has to take at least 2 doses of TD vaccination. Or if her pregnancy is within 3 years of her previous pregnancy, at least 1 dose of booster vaccination. So these are the 4 criteria to satisfy the definition of booked case. So she has to be registered in the nearby government facility. The second important thing, what she has to do, she has to take at least 100 days of iron and calcium. She has to have at least 4 antenatal visits. And the last one is she has to take at least 2 doses of TD vaccination. So this we call it as booked case. So now, as I already spoke about number of visits. One second, I'll erase all this. So we spoke about number of visits during pregnancy. So we have to know what does Foxy recommend and what does the universal guidelines, that is universal is WHO. So what does WHO recommend? So both of these are important for us to know. So previously, what we used to tell, the ideal number of visits during pregnancy, at least monthly visits till 28 weeks, fortnightly visits till 36 weeks, and weekly visits thereafter. So this was the standard thing which was told in all the books and also guidelines. That is ideal. Ideally, a woman should undergo so many visits. But what are the minimum number of antenatal visits which are recommended? So there was something called as WHO FNAC model, that is focused antenatal care model, which recommended at least 4 visits during the pregnancy. But in the year 2016, they completely changed the concept of 8 contacts. So, what do you mean by contacts? So, what is a visit? If the pregnant mother goes to the healthcare facility, we call it as visit. But if the pregnant mother either going to the healthcare facility or the healthcare worker meeting the pregnant woman, so there is contact between the pregnant mother and the healthcare professional or the healthcare team. So that is called as contact. So we have to understand that antenatal care is decentralized. It is not that only an obstetrician is giving antenatal care, an ASHA worker is giving antenatal care, an ANM is providing antenatal care, a medical officer is providing antenatal care, and also a specialist like a OGN is also providing antenatal care. Why? Because we need this care to be redistributed to all levels of population. So if the woman is not able to come to the healthcare facility and get the necessary benefits, the healthcare worker goes to her household, gives her a TD vaccination, or collects her urine and blood for hemoglobin and urine analysis and tells that everything is normal. So this is an approach which has been formed now by the WHO. And they've clearly told these 8 contacts have to be distributed between the first trimester, second trimester, and third trimester. So before, what they used to tell, so there was a normal pyramid of antenatal care. So what they used to tell, first trimester, if the woman registers also, it is okay. If she does not register also, it is okay, like that. But the most number of visits were to the third trimester. So first trimester, second trimester, and third trimester. But now we no more follow the regular upright pyramid. Instead, we follow the inverted pyramid. So why this is very important? So they give more importance to first trimester screening and first trimester booking. Why? Because in the first trimester, we are able to we are able to do the booking investigations. We are able to screen for preeclampsia. We are able to screen for gestational diabetes mellitus. We are able to screen for aneuploidies. We will screen for anemia. So we'll screen for hypothyroidism. So all this is happening in the first trimester. So they told that the first trimester should be given the utmost importance when compared to the third trimester. So this is the recent concept of inverted pyramid model of antenatal care. So this has to be remembered, and it is a nice to know thing for postgraduates. And this eight contacts are also been told that this has to also be remembered by you. So the first contact is 12 weeks, then 20 weeks, then 26 weeks, then 30 weeks, then 34 weeks, then 36 weeks, and then 40 weeks. So these are the eight contacts: 12, 20, 26, 30, 34, 36, and 40. And if she's not delivered by 40, an additional visit at 41 weeks is recommended. So this is recommended by WHO guidelines, and it has also been inculcated in our FOXY antenatal care guidelines as well. So these are the eight important contacts which the pregnant mother should have. And next, what is important for us to know is what is done in the part of first visit booking investigations. So whenever a woman comes to you for the first visit, she tells, I've just done an UPT, it is said to be positive, so you have to do an ultrasound, confirm the pregnancy, and do the booking investigations. So what are all the booking investigations you want to do? So these are the important booking investigations which you have to do. So what are the blood group and RH typing? So here you will diagnose whether it is an RH positive pregnancy or an RH negative pregnancy. So if it is an RH negative pregnancy, we have to obviously do husband's blood group. And if the husband's blood group is RH positive, then we will do something called as indirect Coombs test to know whether it is an alloimmunized pregnancy or a non-alloimmunized pregnancy. So that we'll discuss in our detailed in RH negative class. But you have to know first basic investigation you will do is blood grouping and RH typing. Next you will do CBC, that is complete hemogram, or if there are facilities where CBC is not available, at least we have to do a point to care test of hemoglobin, where you can use a Sally's hemoglobinometer and check the hemoglobin. The next important investigation you will do is the screening for diabetes, GDM. So what we have adopted in India is the DIPSY method. So what is DIPSY method? Listen to me carefully. 75 grams of glucose is mixed with 200 ml of water, and it is taken over a period of 10 to 15 minutes, and the blood glucose analysis has been done after 2 hours. If the woman, and this is all done irrespective of the last meal taken. So it does not need any fasting state. So what we are doing, we are giving a glucose load to the pregnant woman and challenging the endogenous insulin production to see whether it is maintaining the normal blood glucose level or not. So pregnancy is obviously the diabetogenic state. So we have to always screen for GDM. And India is the diabetic capital of the world. So in other UK and US, so HCOG, RCOG guidelines, they only recommend risk-based screening. So only who have previous history of GDM, previous history of stillbirth, or family history of diabetes or obesity, only them they will screen. But in India, because all of us are susceptible to development of gestational diabetes mellitus, we have to follow a universal screening protocol. So irrespective of the last meal taken, 75 grams of glucose is measured, put it in 200 ml of water, pregnant mother is asked to drink it, and after 2 hours the blood sample is taken, the venous blood sample is taken, and the analysis is done. And if it is less than 140, it is normal. If it is more than 140, we have to diagnose gestational diabetes mellitus. If it is more than 200, it is one of the characteristics of overt diabetes mellitus which has been masked previously or not checked during her pre-conceptional period. So that is why screening of GDM is important. The next important investigation is the serology. So what all we have to do? We have to do HIV testing, HBsAg testing, and syphilis in the form of VDRL. And the other important thing you have to do is the TSH. Why TSH is important? Because the fetus is entirely dependent on the mother for the thyroxine, and that is why you have to do TSH, which is very important. So at this point, I would like to discuss the new guidelines according to American Thyroid Association. So American Thyroid Association has been given newer guidelines for management of thyroid disorders in pregnancy. So previously, what was the guideline which we used to tell? TSH, first trimester, second trimester, third trimester, the levels were 0.1 to 2.5, 0.2 to 3, 0.3 to 3 micro international unit per ml. So this was the normal cutoff of TSH during each trimester. But now this has been no more followed. So according to ATA 2026 guidelines, the threshold of TSH is between zero point 0.1 to 4 micro international per ml. And they also tell if there is overt hypothyroidism. So what do you mean by overt hypothyroidism? That is, there is raised TSH, raised TSH plus low FT3. So when the TSH is high, but the FT3 value is low, that time you call it as overt hypothyroidism. So in overt hypothyroidism, they take that if it is less than 6 in the first trimester, you still wait and watch for at least 2 to 3 weeks. So if it normalizes, 1 second. So if it normalizes after 3 weeks, then you need no treatment. But if it is more than 6 after 3 weeks or in the second or third trimester, you have to start with levothyroxine. So what is the dosage of levothyroxine? It is around 1.5 to 1.7 microgram per kg per day. So if she's around 60 kg, you have to start 75 microgram per day. Fasting, early morning fasting state, it has to be taken for better absorption. So this is regarding to overt hypothyroidism. So what about subclinical hypothyroidism, where TSH is high but T3, T4 are normal? So whenever there is subclinical hypothyroidism, if the level of TSH is more than 10, you have to definitely treat. If the level of TSH is between 4 to 10 in the first trimester, you have to do anti-TPO antibody. If the anti-TPO antibody is positive, then you have to treat. But if it is between 4 to 10 in the second and third trimester, again you have to treat with levothyroxine. So these are the guidelines, and this is also a recent changed update which you all have to be remembering, and this might be asked in your exams as well. So ATA guidelines 2026, I will repeat once again in a brief note. The threshold value of TSH is 0.1 to 4 micro international unit per ml. In overt hypothyroidism, if there is raised TSH with low FT3, if the TSH is less than 6 in the first trimester, wait for 2 to 3 weeks. If it normalizes, no need to treat. If it does not normalize, or if it is more than 6 in the second and third trimester, then you have to treat with levothyroxine. What is the dosage? 1.5 to 1.7 microgram per kg per day. And then when you have to repeat after 4 weeks and see if it is normalized, and at least till mid gestation, that is 20 to 24 weeks, repeat every monthly. And if it is normal, once you repeat at 30 weeks of gestation, and if it is still normal, you can continue the same dose. Once she delivers, you can go back to the pre-pregnancy dose, or you have to monitor after 6 weeks and do the dose alterations. And if it is subclinical hypothyroidism, if the TSH value is high with the normal FT3, FT4, then the cutoff more than 10, treat 4 to 10 in the first trimester, do anti-TPO antibodies. If it is positive, then you treat. But if it is negative, don't treat. But if it is between 4 to 10 in the second and third trimester, then definitely treat with levothyroxine. So how much you have to increase? So for example, if she's already on Tyronol, that is levothyroxine, around 25 mg. By 12 weeks, you have to increase by 25%. And by 20 weeks, you have to increase by 50%. For example, if she's taking 25 microgram, by 20 weeks, you have to increase to around 37.5 microgram. So that is how you have to increase. After pregnancy, you have to check her TSH value minimum after 6 weeks to decide whether to continue or not. If it is less dosages of 25-50, you can stop and repeat TSH after 6 weeks. But if she's already hypothyroid prior to pregnancy, it is better to shift to the pre-pregnancy dosage. So I hope you have understood. It is slightly confusing to understand at the first point, but if you read the guideline in depth, you will understand. So after this class, I will be sharing you this ATA thyroid update, the important points, and also I will share you that the table in Williams with respect to corrected expected date of delivery. So all these important tables and updates I will share to you. Okay. So what all booking investigations we have to do? Blood grouping, RH typing, complete hemogram, TSH, screening of gestational diabetes mellitus, and serology, that is HIV, HbSAg, VDRL, and urine examination has to also be done. So very important is to do a urine culture rather than urine routine. Why urine culture is important? Because there is something called as asymptomatic bacteriuria. So what is the meaning of asymptomatic bacteriuria? The woman might not have any symptoms of urinary tract infection, but if you do a urinary culture, there might be more than 10 to the power 5 colony forming units of a single microbial organism in a midstream clean catch specimen of urine. So you have to collect the urine in a midstream clean catch container. So you have to avoid the first void because it might be contaminated. So midstream urine should be collected in a clean catch container, and then this has to be cultured. And if the has culture positive of more than 10 to the power 5 colony forming units of a single organism, then you consider that there is asymptomatic bacteriuria and the risk of development of pyelonephritis or preterm labor or PROM or PPROM is very high with asymptomatic bacteriuria. That's why it has to be diagnosed and it has to be treated. So usually during pregnancy, we give a course of nitrofurantoin 100 mg BD for 7 to 10 days, and this might be enough. And or if you have done a culture, we will know the culture sensitivity, and based on that, what antibiotics which are safe in pregnancy can be advocated to the patient. But the examination has to be done in the first booking visit only. So that is about booking investigations. The next important thing is the folic acid supplementation. So there are two types of folic acid supplementation. One is prophylactic folic acid administration. The second one is therapeutic folic acid administration. So what does the national guidelines tell? So we have to give prophylactic. So for every pregnant mother, at least 400 microgram of folic acid has to be supplemented. 400 microgram of folic acid has to be supplemented till 12 weeks of gestation. And there is something called as preconceptional intake of folic acid. So why this preconceptional intake of folic acid? So usually an undergraduate will tell what is the importance of folic acid in pregnancy to prevent neural tube disorders. But how does folic acid prevent neural tube disorders? Because folic acid is important for the closure of the neural tube. So the neural tube has an anterior neuropore and a posterior neuropore. The anterior neuropore closes by 24 days after conception. The posterior neuropore closes after 28 days of conception. So when a folic acid not administered, for example, she will not be taking folic acid. So this might cause neural tube defects because you will start only after 1.5 months after confirmation of her pregnancy. That time there is no use. So that is why it is very important for us to emphasize the need for folic acid prior to conception. That is, taking preconceptional folic acid minimum of 400 microgram 12 weeks prior to conception and continuing after pregnancy confirmation till 12 weeks of gestation. So that is prophylactic folic acid administration. So what is therapeutic folic acid administration? So if there are any other high risk categories. So there are five important indications for therapeutic folic acid administration. That is 5 mg of folic acid. So what are they? Previous history of neural tube disorders. If the if the pregnant mother is on any anticonvulsant drugs, if she is a case of overt diabetes mellitus, if she has folic acid deficiency anemia, or if she has any hemoglobinopathies like sickle cell anemia or thalassemia. So these are the five important indications for therapeutic folic acid administration. So what are they? There are previous history of neural tube disorders, mother on anticonvulsant drugs, or if she is a overt diabetes mellitus case, or if she has any hemoglobinopathies, or if she has absolute folic acid deficiency anemia. So that time you have to give 5 mg of folic acid. But routinely in our hospitals, we prescribe 5 mg to all women for benefit. This to benefit ratio, we provide 5 mg of folic acid. So that is the difference between prophylactic folic acid administration and therapeutic folic acid administration. So I hope you people have understood till here. The next important thing is what is the vaccination which is important in pregnancy. So immunization or vaccination update during pregnancy is also important. So this also has an update. So you don't bang your heads that so many updates, so many guidelines. But if you keep on revising and you have to keep on updating yourself because the things which were there during my PG days were not the same as present scenario. So there are so many updates, there are so many guidelines which have been changed, and we also have to change our clinical practice according to the evidence-based guidelines. Why? Because in future, if you face any medical legal complication or anything you have to answer in court, you have to have a valid evidence. So if you're doing a evidence-based practice, you will be able to stand in the court of law and tell that your treatment was based on current evidence. So no one will ask you whether you have done it out of your experience or practice. They will ask you, what does the evidence say? So if you are following the current evidence, you're always safe. So many people argue telling, oh, this is not the way we used to do in our hospital, or this is not what I'm practicing in my medical college. But no one is interested in what you were doing. They are interested in what the current evidence says. And I always believe in evidence-based practice, and we have to always update our knowledge according to the recent clinical guidelines, because it is not that they've just released a guideline. There is so many studies and research and meta-analysis behind all this to form a guideline. So that is why we have to never neglect the evidence. So present ACOG 2026 update on immunization. So usually what all immunization we are interested in. So firstly, we use TD vaccination. So TD is the basic vaccination which we are keeping on reading from our undergraduation. So before it was TT and now we have moved to TD. So what is the importance of vaccination during pregnancy? So it causes active immunization of the mother, and the formation of antibodies lead to passive immunization of the fetus. So how many doses of TD are recommended during pregnancy? 2 doses are recommended. When is the first dose recommended? As early as the first visit. Why we want the mother to take during the first visit? Because she might not take and she might not come back for antenatal checkup. So you do not want to miss her to take her immunization. So it is preferably given during the first trimester. It can be given as late as 16 weeks also. But why we prefer in India, in our country? Because many women, they fail to come after first visit. They tell everything is normal. Then fifth month, sixth month, directly they'll come for anomaly. So that's why we don't want to miss out her, and we don't want to miss if she has any abortion as well. So that is why first visit, first dose is given. and the second dose is given after 4 to 6 weeks. So why two doses of TT is or TD is given? So this I have multiple times repeated when to my students, both in UG classes and PG classes, the concept is very clear. So the first dose of TD injection is being given for development of IgM antibodies. So this is a primary immune response. So primary immune response helps in generation of IgM antibodies. So these antibodies are very large. The molecular weight is around 950 kilodaltons. They cannot cross the placenta and provide passive immunity to the fetus. So it requires at least 4 to 6 weeks for the development of IgG antibodies. So then after 4 to 6 weeks, we give the second dose and this leads to secondary immune response. So this secondary immune response helps in generation of IgG antibodies. And these IgG antibodies are small. So these are only 150 kilodaltons. They can easily cross the placental barrier and they develop or they cause passive immunity to the fetus. So that is why we don't give 3 or 10 or 1 TD injection. Two doses of TD are recommended. First in the first visit, second after 4 to 6 weeks. First is for primary immune response. 1 second. First is for primary immune response for the generation of IgM antibodies, and the second is for generation of IgG antibodies. So that is why these two doses of TD is important. The second thing is if she's become pregnant within 3 years of her previous pregnancy, so one dose of TD is enough. So that is the booster dose, which is usually given in the second or late second trimester or in the third trimester. So why booster dose is sufficient? Because 3 years, the antibodies have that minimum inhibitory concentration is maintained to prevent tetanus. So it prevents tetanus in the mother and it prevents tetanus neonatal in the fetus. So that is why booster dose is important. So once TD and TD second dose is given, there is something which has been incorporated now in the immunization schedule, that is Tdap, that is tetanus, diphtheria and acellular pertussis. So this is usually given between 27 to 36 weeks of gestation. 27 to 36 weeks of gestation. So why is it given then? So it helps in the generation of antibodies, and these three dreadful bacterial diseases which can cause perinatal mortality in the fetus will be prevented if you do give a Tdap injection between 27 to 36. So some guidelines tell give Tdap irrespective of 1 or 2 TD injections. Some tell that give first dose of TD and instead of second dose, directly give Tdap between 27 to 36. So there is no harm in giving all these three vaccinations. Or if you miss the second one also, you can directly replace the second one by giving Tdap Tdap vaccination between 27 to 36 weeks of gestation. So what are the other updates according to ACOG? So Tdap, TD, and they also emphasize the importance of giving COVID vaccine either in any of the trimester at least once for the prevention of COVID infection. So they also tell COVID vaccine can be given in any trimester in pregnancies and it is safe in pregnancy. And the third important vaccine they tell is the influenza or flu vaccine, especially in the flu season, in the fall season, which is usually in the September to November period. It can be given and preferably given in the second trimester. And the last one is the respiratory syncytial virus vaccine, especially if a pregnancy is falling between September to November. And if the gestational age is more than 28 weeks, better to give one dose of RSV virus. So what RSV vaccination? So what we have to remember with respect to vaccination is live vaccines are completely contraindicated during pregnancy. So what are the live vaccines? Hepatitis, sorry, mumps, measles, rubella. So all these are completely contraindicated in pregnancy. So what are safe vaccines? Killed vaccines or toxides or live attenuated vaccines are safe during pregnancy. So that is why you can give TD, Tdap, flu vaccine and RSV vaccine. So this also has a ACOG update on vaccination table, which I will be sharing on group. So this is important with respect to vaccination. The next important thing is we have to ask other history in the first trimester. So, what are the important history? History of excessive vomiting, bleeding PV, spotting PV, fever with rash, teratogenic drug exposure, and radiation exposure. So, usually there is vomiting in pregnancy, mainly because of secretion of beta HCG. So, what does beta HCG do? It goes and stimulates the vomiting center in the brain, that is chemoreceptor trigger zone. So it stimulates that, which causes vomiting during pregnancy. But we have to differentiate between nausea and vomiting in pregnancy and hyperemesis gravidarum. So, what is hyperemesis gravidarum? If the vomiting during pregnancy is causing problem to her present day-to-day activities, if the woman is getting hampered of her day-to-day activities during pregnancy because of nausea and vomiting, we call it as hyperemesis gravidarum. So there are certain criteria to describe hyperemesis gravidarum, that if there is more than 5% of weight loss, or if there is associated ketonemia or ketonuria, or if there is any electrolyte disturbance, all these go in favor of diagnosing of hyperemesis gravidarum. And we have a designated scoring called as puke score, that is pregnancy unique quantification of MSS score, and based on the score we can decide whether the woman needs outpatient management or daycare management or inpatient management. And also we have a guideline which is being formed for hyperemesis gravidarum, that is the GTG guideline according to RCOG. So they have given a beautiful guideline for diagnosing hyperemesis, the criteria, the classification or puke score, and based on the puke score, what are the different lines of management. So that is also important with respect to hyperemesis gravidarum. So that is, we have to ask about excessive vomiting. And also we have to ask about bleeding PV and leaking PV. So we have to always differentiate if she has any spotting PV. For example, she has spotting PV and you have done a perspeculum examination, there is some brownish discharge, os is closed. Then you do a scan, there is small subchorionic hemorrhage, but the fetal heart is all normal. Then you diagnose a threatened abortion. So there are different types of abortion: threatened abortion, incomplete, complete, or if there is any associated sepsis, septic abortion. So all these have to be ruled out, and we have to see what type of bleeding it is. So whether it is an inevitable abortion, or a threatened abortion, or an incomplete abortion has to be checked. One second. Okay. So next, that was about hyperemesis and bleeding PV. Next, we have to also ask about fever with rash. So whether she had any fever and associated rash. So we have to diagnose different infections. So whether it was a first day rash or a second day rash, whether we have to rule out any congenital infections, especially toxoplasmosis, rubella, or herpes. All these infections have to be ruled out, and varicella. So that time we can know that they have any congenital implications like congenital varicella syndrome and cerebral implications of cytomegalovirus and toxoplasmosis. All this has to be discussed with the women. And all of you know the teratogenic drugs. So there are list of teratogenic drugs which might cause defects in the fetus and the newborn. So we have to see whether she was in drugs, she was on any preconceptional drugs like warfarin, or whether she was in on any antihypertensive drugs like AC inhibitors or ARBs, or she was using any convulsants like sodium valproate or phenytoin. So all these are teratogenic drug exposure. So you have to ask her a detailed history of teratogenic drugs, and this causes some implication during her pregnancy. So this has to be elicited in the first trimester, because congenital malformation due to drugs is most common in the first trimester, because the embryogenesis is between 6 to 8 weeks of gestation. And then very important is the radiation exposure. So what is the radiation exposure which is permissible during pregnancy? In the first trimester, it is 2.5 rads. And in the second trimester and third trimester, it is 5 rads. So usually some might ask you, what is the exposure of a chest X-ray? So chest X-ray usually is less than 0.01 rads. Okay, so this is a very little exposure. So one time exposure of chest X-ray will not cause any teratogenicity in the fetus. So, but still, whenever you're doing a chest X-ray or you're doing any extremities X-ray, if she sustained any fracture, you have to always use an abdominal lead shield to prevent the radiation exposure. And modalities like CT are completely contraindicated during pregnancy. Only X-rays, that too with an abdominal shield, is recommended only if it is indicated. Otherwise, CT is completely avoided, or it has to not be done during pregnancy. So these are the very important first trimester things you have to know. And when you come talk about USG, as I told you, we have to diagnose missed abortion also based on USG parameters, because usually we do missed abortion is whenever there is no clinical symptoms, but it only has an ultrasound criteria to diagnose missed abortion. So what is the ultrasound criteria of missed abortion? So if the gestational sac is more than 25 mm, but there is no fetal pole or cardiac activity, you call it as missed abortion. Or if the CRL is more than 7 mm with no cardiac activity, then you call it as missed abortion. Or if there is GSAC and you wait for 14 days and there is still no fetal pole or cardiac activity, then you call it as missed abortion. If there is GSAC plus yolk sac, you wait for 11 days and there is still no fetal pole or cardiac activity, again you call it as missed abortion. So this is the 4 important characteristics of first trimester ultrasound to diagnose missed abortion. So missed abortion, if the GSAC is more than 25 mm, no fetal pole or cardiac activity. If the CRL is more than 7 mm, no cardiac activity. If the GSAC is present, you wait for 2 weeks, but there is still no fetal pole or cardiac activity. If the GSAC along with yolk sac is present, you wait for 11 days and still there is no fetal pole or cardiac activity. All these are characteristics of missed abortion. So that time you have to plan for termination of pregnancy. Next, what is important with respect to the second trimester? So what is important? The first important thing you have to ask is quickening. So what is quickening? It's the perception of fetal movements by the mother for the first time during pregnancy is called as quickening. So what does it emphasize? It tells that the fetus is viable, and also the average gestational age can be computed with the history of quickening. So usually in a primigravida, quickening occurs around 18 to 20 weeks, whereas the multigravida is around 16 to 18 weeks. So that is the importance of quickening. Why the primigravida perceives it late? Because the abdomen tone is very taut, and the perceptions might not be felt for the first time. But in multis, they already have the previous experience of the movements of the baby. So she might perceive a little earlier, like 2 weeks earlier when compared to primi. And in multi, what happens? Even the abdominal wall tone is reduced. So that is why the perception can be easily felt. So that is the importance of quickening during pregnancy. So you have to tell quickening felt at 5th month of amenorrhea or 5.5 months of amenorrhea. And once you have mentioned about quickening, subsequent visits you have to mention about the perception of fetal movements. It's always a reassuring sign that the fetus is viable if she's perceiving the fetal movements well. The second important thing in the second trimester is iron and calcium supplementation. So there are two important things you have to remember about iron in pregnancy. So what things you have to remember? What does the national guidelines, that is the FOXY guidelines, tell? What does the WHO guidelines tell? So both recommend prophylactic administration of iron. So how much? National guidelines 100 mg of elemental iron for 180 days during pregnancy and 180 days after pregnancy, starting from the second trimester. So usually in the first trimester, there is nausea, hyperemesis. The woman might have GI discomfort or GI upset. So usually iron is not recommended in the first trimester. So it should be started from the second trimester. So 180 days means 6 months. So from third month to ninth month. And after the delivery also 6 months she has to take sufficient iron for the replenishment of the stores and to come back to the previous state. So this is the FOXY guidelines. But what does WHO tell? The WHO tells 60 mg of elemental iron at least for 180 days during pregnancy. Before they used to tell 100 days, but now they have clearly told that it should be given for 180 days during pregnancy. And the WHO also tells if she is anemic. So if the CDC, what is the CDC cutoff for anemia? If the hemoglobin is less than 11 in first and third trimester and less than 10.5 in the second trimester, this is regarded as anemia. So if there is anemia, therapeutic administration of iron has to be given. So double dose iron. So you have to make it 120 mg. And WHO also tells if the woman is not willing to take daily doses of iron, she can take weekly doses of iron. So how much they prefer to give weekly? So they tell that at least 120 mg plus 2800 microgram of folic acid is administered weekly. So weekly, one tablet of 120 mg of elemental iron along with 2800 microgram, that is 2.8 mg of folic acid weekly, or 60 mg of elemental iron daily. But if she has an element of anemia, you have to double the dose, that is 120 mg per day has to be taken. And when it has to be taken, usually iron is preferably taken in the morning times. So why is it taken in the morning? Because the hepcidin values in the body are slightly low. So whenever the hepcidin is high, it prevents the absorption of iron. So that is why in the body hepcidin levels are low in the morning. So the better absorption of iron, and it is preferably taken before meals in the empty stomach, because acidic state will help in absorption more, but it causes GI symptoms and nausea and vomiting. So we do not advise the woman to take it in fasting state. We ask the woman to take at least 30 minutes after her meals so that she will not have that much GI discomfort. So that is about prophylactic administration of iron and therapeutic. And we have to also check the compliance, whether she's taking iron or not. So we have to check the used sheets. We have to ask the color of her stools, and we have to ask whether she has any constipation. All these are certain symptoms which tell that the patient is compliant to iron therapy. And calcium, minimum 1.5 to 2 grams of calcium, 1.5 to 2 grams of calcium per day is recommended, because this is very much important for the development of fetal skeleton, bones, everything, and teeth. So this is very important, and it is always from the mother to the fetus, it has been transported. So we usually give it in divided doses. So we usually take 500 mg in the afternoon, 500 mg in the night, another 500 mg take in the form of dietary supplements like a glass of milk, one glass in the morning, one glass in the evening. And very important thing you have to know is do not take iron and calcium together, because this hampers the absorption of iron. So iron usually should be taken with the orange juice or lemon juice before food, and all this. It should never be taken with tea, coffee, or calcium tablets like that, because this phytates, tannates, oxalates, all these will hamper the absorption of iron. So if iron is taken in the morning, calcium should be taken in the afternoon and night times. And hypocalcemia is also one of the risk factor for development of preeclampsia. So that is also very important. And the third important thing is an anomaly scan. So what is anomaly scan? A detailed scan which is done between 18 to 23 plus 6 weeks of gestation. So what do we do in anomaly scan? Three important features of anomaly scan. So what do? You do head to toe fetal anatomical survey. So whether the calvaria is good, brain, facial profile, the spine, heart, abdomen, kidneys and bladder, the stomach, then limbs, upper limb, lower limb, the genitalia, everything has been observed in the anomaly scan. So anomaly scan should be preferably done between 18 to 23 plus 6, and that is called as a TIFA scan, that is targeted imaging of fetal anomalies. And what else is important in anomaly scan? One is the fetal anomalies. The second one is the cervical length. So the length of the cervix usually is around 3.5 to 4 centimeter. But if it is less than 2.5 centimeter, we call it as a short cervix, which warrants attention. So that is also important. And the placental location. So usually some radiologists or gynecologists describe that the placenta is low lying in the NT scan. It does not carry any importance. So the placenta has to always be commented in the anomaly scan. So the location of the placenta, whether it's in the upper segment or lower segment. And if it is in the lower segment, if it is within 2 centimeter from the internal os, it should be considered as previa. So only then you have to confirm it by transvaginal ultrasound, and you have to repeat an ultrasound for placental location at 32 weeks of gestation to confirm whether it is placenta previa and manage the pregnancy. And if there is any prior cesarean or prior uterine scar, you have to also rule out placenta accreta spectrum by doing 3D analysis or placental bed Doppler also. So what is the importance of anomaly scan? The anatomical survey, fetal anatomical survey, cervical length, and the placental location. And the screening of gestational diabetes in first visit, again, it has to be repeated between 24 to 28 weeks of gestation. So I will tell you. So booking, you have done CBC, all those investigations which I told, along with, sorry, one second. Booking, you have done all those CBC, TSH, DIPSI, serology, blood group. Next, when will you repeat? So you will do between 24 to 28 weeks. You will again do CBC, urine routine, preferably culture, and along with DIPSI. Again, at 32 weeks, you will do CBC, urine routine, or preferably culture. Again, at term, when she comes for delivery, again you will do CBC, urine routine. So this number of times you have to repeat her hemoglobin. So hemoglobin has to be done in booking visit, repeated between 24 to 28, again at 32, and term, because hemodilution occurs maximum between 32 to 34. We have to repeat it. And urine routine also has to be done. And now in the recent national guidelines, if it is a high risk woman, for example, if she has previous history of PCOS, previous history of GDM, or if she has obesity or overweight, such woman, we also repeat DIPSI at 32 weeks of gestation. Once again, even though it is done between 24 to 28 and it is said to be negative, again at 32 weeks, we will repeat this. So these are the number of times to screen for GDM. And one important thing I forgot to tell you, during booking investigation, we have to also do screening for preeclampsia. So screening for preeclampsia is done by doing a mean uterine artery PI And if it is more than 95th centile, we have to tell that it is a high screen for or high risk for preeclampsia. So there are two important modalities. One is the Foxy-Gestosis score. So there are around 37 parameters which are given a score of 1, 2, and 3. And if the score is more than or equal to 3, we have to start with ecospirin 75 mg during the night times from 12 weeks of gestation, preferably less than 16 weeks up to 36 weeks of gestation. I will repeat, if the Foxy-Gestosis score is more than or equal to 3, it is regarded as high risk and we have to start with ecospirin 75 mg during the night time as early as 12 weeks, preferably less than 16 weeks, and up to 36 weeks of gestation. But if you're doing a multimodal screening, so what do you mean by multimodal screening? Taking the maternal characteristics into consideration, we will take the mean arterial pressure, we will take uterine artery Doppler, mean uterine artery Doppler pulsatility index. Along with that, if you take the serum PLGF and combine this and do a multimodal risk-based screening, and if it is positive for preeclampsia, then you have to give 150 mg of aspirin, that too in the night times from 12 weeks, preferably less than 16 weeks. If it is not given at 16 weeks, preferably till 20 weeks also, you can start ecospirin. And once you start, you will continue up to 36 weeks, or you can continue even up to delivery. There is no problem. So that is with respect to screening of preeclampsia in the first trimester with using Foxy-Gestosis score or multimodal screening. And as a part of second trimester history taking, we have to ask about premonitory symptoms. So before we used to call it as imminent symptoms, this headache, nausea, visual disturbances, and epigastric pain. All these we used to call it as imminent symptoms of preeclampsia or eclampsia. But now the new Foxy guideline has been released, and they clearly tell that it is replaced by the term premonitory symptoms. So about each of the symptom we'll discuss in preeclampsia class. So that is about second trimester. And in the third trimester, again, we will ask about perception of fetal movements, continuation of iron and folic acid supplementation, and we will ask about growth scan. So when do you want to do a growth scan? So you want to do a growth scan preferably between 32 to 34 weeks of gestation. And if it is a high risk pregnancy, then you will do between 28 to 30 weeks of gestation. So what do you mean by growth scan? You will do the fetal biometry, that is BPD, head circumference, abdominal circumference, femur length, and you will insert into the monitor. It will give you the estimated fetal weight. So once you get the estimated fetal weight, you have to see whether it falls between 10th to 95th centile to be normal. So if the estimated fetal weight is less than 10th centile, and if it is associated with any Doppler changes, or if it is less than 3rd centile, you diagnose FGR in that woman. So then if you diagnose FGR, she requires frequent growth scan and Doppler monitoring, and we have to plan her delivery accordingly. And if it is more than 95th centile, again, she falls into a category of large gestational age, and again, we have to decide on mode and timing of delivery in such cases. And in our FGR class, we will discuss about minor risk factors and major risk factors when you have to repeat the screening for fetal growth restriction, and how do you manage a case of fetal growth restriction based on ultrasound parameters. So this growth scan preferably done during 28 to 30 weeks in a high risk pregnancy and 32 to 34 in a low risk pregnancy is important, and we repeat the growth scan at the term gestation. So at least the interval should be minimum 3 weeks for fetal biometry to be done. The interval should be at least 3 weeks to know whether there is any growth lag or not. So we can repeat by around 37 to 38 weeks, at least to know the estimated fetal weight, the amniotic fluid index, the presentation of the baby, and then to confirm what mode of delivery you want to go for. So in Indian settings, if the baby's weight is more than 4.5, preferably the chance of vaginal delivery is slightly less, and you might counsel them for cesarean section. So if the pelvis is borderline, so that is important with respect to growth scan and third trimester. And in again third trimester, we have to ask about all premonitory symptoms of preeclampsia. Next, menstrual history. So, a part of history taking, we have to ask menstrual history, past history, family history, and personal history. I know it is late and all of you are slightly tired. So, I will take another 20-25 minutes and wrap up the session. But all these are important as a part of history taking. So, what is important with respect to menstrual history? We have to ask her about her previous menstrual cycles, the regularity of the cycles, the duration of the cycles, whether she used any clots, no, sorry, whether she used how many pads per day, whether there was associated with clots or dysmenorrhea. And whenever you ask about her previous menstrual cycles, you have to know whether her LMP is belonging to good, excellent dates, good dates, or poor dates. So only some books describe this. So some examiners, old time examiners, are interested in knowing what is excellent dates, good dates, and poor dates. I will tell you what is it, but you have to go back and watch this class once again for better understanding. So, what is excellent dates? Whenever a woman knows her LMP, she has regular cycles, she has not used any OC pills in the past 3 months, and she has the corresponding uterine height, and she has one ultrasound between 16 to 24 weeks of gestation, which is corresponding to the gestational age, then you call it as excellent dates. If there is no clinical relevant information, but she has two scans between 16 to 24 weeks of gestation, which is corresponding to the gestational age, then again it is called as excellent dates. What is good dates? If she has relevant clinical history, that is, she knows her LMP, there are regular cycles, no prior history of usage of OC pills, but the scan is done after 24 weeks. If one scan is done, it is good dates. If there is no relevant clinical information, but two scans are done and there is significant the significance of the interval between the two scans is corresponding to the gestational age, then it is called good dates. If the above two scenarios are not there, either she doesn't know our clinical information or scans are not done, then you consider it as poor dates. So this is a very important thing a postgraduate student must know. So they will ask you, what is the importance of excellent dates, good dates, and poor dates? So that must be emphasized. Next, past history. You have to know about past medical history, surgical history, and blood transfusion history. So, what about the past medical history? Diabetes, hypertension, TB, asthma, epilepsy, thyroid, and cardiac disorders. So, these are the 7 important things you have to ask in past medical. So, diabetes, hypertension, TB, asthma, thyroid, epilepsy, and what I forgot? Hypertension, diabetes, thyroid, asthma, TB, and cardiac disorders. So all these has to be asked. And past surgical history, whether she has any previous history of appendicectomy or perforation or myomectomy, all these are important of past surgical history and past blood transfusion. So if she's a previous case of anemia, it might have antepartum, intrapartum, and postpartum consequences. So that is also important with respect to past history. Next, family history. Again, the important medical disorders which are running in the family is important, and that is very one of the important risk factor of development of GDM. The second important thing, if there is any congenital anomalies or twinning in the family, especially maternal twinning, is also one of the important characteristic of twin pregnancy. So that family history also has to be elicited. Next, personal history, diet, appetite, sleep, bowel and bladder activities, and along with any health affecting habits. So, in diabetes and anemia case, you have to take a detailed 24 hours recall method. You have to write the diet chart. We have to take the total calorie requirement, total protein requirement, and we have to see whether it is matching, and we have to see the calorie deficit and the protein deficit. Especially dietary history must be clearly mentioned in the diabetes and anemia cases. And with respect to addictions, smoking, alcohol, caffeine, so 300 mg of caffeine, more than 300 is not recommended. Alcohol must be completely avoided. And smoking, both first hand smoke and second hand smoke, must be completely avoided during pregnancy because it can cause FGR and other complications during pregnancy. So that is about personal history. So once you have finished the history taking, you have to summarize the case. So what all is important in your summary? Name, age of the patient or age of the pregnant mother, the socioeconomic status, chief complaints, uh, positive history with respect to HOPI, and positive history with respect to previous pregnancy and present pregnancy. So all this you have to compile and write summary. So this also I have ensured. After history taking, you will summarize the case. After examination, you will go into a provisional diagnosis. But after doing the investigations, you will come to a final diagnosis. So after history taking, summary, after examination, provisional diagnosis or differential diagnosis, and after investigations, you will arrive at a final diagnosis. So if you're the last roll number during your exams and the examiner doesn't have time for you to tell all your history taking, he might ask or she might ask you just to summarize the case. That time, what are the important positive findings in your case has to be detailedly elaborated in the summary of the case. And next important thing is the examination of the patient. So once you have taken a detailed history, what is important? You have to do a general physical examination. So you all know what are the things which are covered under general physical examination. So you have pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. So usually the lower palpebral conjunctiva, the tongue, the palate, the palms and the nail beds are seen for anemia or pallor. And the upper palpebral conjunctiva is seen for icterus, then the cyanosis, clubbing, lymphadenopathy, and you have to see whether there is any edema. And edema, again, you have to differentiate whether it is physiological edema or pathological edema. So how do you differentiate? Physiological edema, usually it is because of hemodilution. It is grade 1 edema. It is not accompanied by any other complications or comorbidities, and it reduces over rest or sleep. But pathological edema, it is progressive. It is usually bilateral and is associated with complications like preeclampsia, anemia, cardiac disorders, or kidney disorders like nephrotic syndrome. So that is how you differentiate between physiological edema and pathological edema. Again, here you have to know the different grades of edema. So up to the ankle, grade 1, up to knee, grade 2, above knee, grade 3. There is generalized edema or anasarca, it is grade 4. If there is no visible edema, but there is gestational weight gain is high, then you call it as occult edema. So these are the important characteristics, and about edema we can in detail discuss in the preeclampsia class. The next important thing is the height, weight, and BMI. So we have to see, and in Indian context, less than 140 centimeter is regarded as short stature. And weight, we will categorize the woman that whether she is underweight or whether she is normal weight or whether she is overweight or she is obese based on her BMI. So BMI is nothing but weight in kg divided by height in meter square. So underweight is between 18 less than 18.5. Normal is 18.5 to 24.9. 24.9 to 30 is overweight. More than 30 is obesity. So in underweight, the gestational weight gain which is recommended is 12.5 to 18. And in normal, it is 11.5 to 16. And in overweight, it is 7 to 11.5. And in obese, it is 5 to 9. So this is the recommended weight gain according to the WHO guidelines. So this has to be seen, and BMI is always calculated based on her pre-pregnancy weight. So based on her pre-pregnancy weight, we'll calculate the BMI and we will calculate the weight gain during pregnancy. So usually we tell the weight gain during pregnancy in a singleton gestation is 1 kg in first trimester, 5 in the second trimester and third trimester. So totally allowed 11 to 16 kgs. But if it is multiple gestation, usually it will be around 16 to 22 kgs in a normal weight woman. So this weight gain is definitely dependent on her pre-pregnancy weight and her BMI. And vitals, we have to check all pulse, BP. BP should be checked in sitting position with the arm the BP apparatus placed at the level of the heart. The arm should be relaxed and the proper size cuff must be tied. It should be tied 1 centimeter above the cubital fossa. And we have to first do a palpatory method, then auscultatory method. And sometimes we have to also calculate the mean arterial pressure. So how do we calculate mean arterial pressure? Diastolic blood pressure plus 1/3 of systolic blood pressure is the mean arterial pressure. If it is more than 65, it is abnormal. And then breast, thyroid, and spine examination is very much important. So, especially in the third trimester, if there are inverted nipples or if there is a flat nipple, you have to ask her to do syringing and you have to ask her to prepare for her breastfeeding phase. And thyroid, if there is any visible goiter or thyromegaly, we have to definitely evaluate. And spine, if you are planning for a cesarean delivery, for example, if there is kyphosis or scoliosis, for you to give the spinal anesthesia or epidural anesthesia for as a part of labor analgesia, it is always important for you to do a detailed spine examination. And systemic examination, even Foxy guidelines tell at least once in her first visit or any other visit, you have to auscultate her chest because you cannot directly end up and see her you have during her labor and she has some murmur. You don't know whether it was there priorly or not. So that is why you have to always not miss on doing a systemic examination at least once in her antenatal period. You have to auscultate her chest, look for cardiovascular system, S1, S2, respiratory system to see whether there are normal vesicular breath sounds, whether there is presence of any added sounds, and we have to look for any neurological examination which is abnormal, that is CNS examination. So that is the part of systemic examination. And we all know that we have to do a detailed obstetric examination, that is the per abdomen examination. And there are 4 important things we have to do. So from when we have to palpate the fundus, we have to palpate from 14 weeks of gestation. So after 14 weeks, we can palpate the fundus just above the symphysis pubis at 12 weeks, at the level of the umbilicus 24 weeks, at the level of skiphisternum 36 weeks, and below the level of the skiphisternum 32 weeks with flanks full is the term gestation. So then you will see whether the abdomen is uniformly distended, the position of the umbilicus, whether the umbilicus is everted or inverted, the presence of linea nigra, especially it is the dark pigmentation which is present between the skiphisternum and the pubic symphysis, which is usually due to increased melanocyte stimulating hormone during pregnancy. And there is tria gravidera because of the stretching of skin because of the gravid uterus. And also you have to examine for any scars, previous section or previous myomectomy or any laparoscopic scars or laparoscopic appendicectomy or a McBurney's incision in case of open appendicectomy. All these scars, sinuses, visible pulsations, peristalsis, and if there are any hernial orifices which are there. So if there is any umbilical hernia or inguinal hernia or femoral hernia, all this has to be examined as a part of inspection. And whenever you're doing an obstetric examination, you have to first ask the mother to void urine, lie down in dorsal position. You will stand on the right side of the woman. You will take a verbal consent. You will warm your hands before you do the palpation. And before you do the palpation, with your left hand, you will correct the dextroversion. So the uterus would have been fallen to the right side. So with your right hand, you will correct the dextroversion, and with your left hand, you will go on palpating for the fundus from the skiphisternum, and then you will be seeing the fundal height. So fundal height is very important, and you have to know where the fundus is less than the period of gestation, where the fundus is more than the period of gestation. So usually less than the period of gestation, wrong dates, oligohydramnios, intrauterine fetal demise, transverse line, and fetal growth restriction. So these are the five important causes of fundus is lower than the period of gestation. What if the fundus is more than the period of gestation? Again, wrong dates, full bladder, molar pregnancy, polyhydramnios, multiple gestation, uterine fibroids or uterine masses, adenic cell masses. All these are the important characteristics, or these are the causes of fundus, which is more than the period of abruption. So all these are the causes of fundus more than the period of gestation. So once you calculate the fundal height, then you will ask the mother to lie down in supine position, take the measuring tape, put the fixed part of the tape, that is 0 at the symphysis pubis, and measure till the fundus. So you will get the symphysis fundal height. So fundal height, that is SFH, is important as a part of palpation. Why is it important? Because you will have a clinical estimate of fetal weight. So how do you calculate? Mainly by Johnson's formula. So how do you calculate? Estimated fetal weight is equal to fundal height minus 12 if the head is unengaged, 11 if the head is engaged, into 155. So you will get estimated fetal weight in grams. So this is one of the importance of fundal height. And sometimes you can calculate the gestational age by fundal height into 8/7. You will be able to calculate gestational age in weeks. So that is called as McDonald's formula. So Johnson's formula and McDonald's formula. But Johnson's formula has to have two important prerequisites. One, it should be a singleton pregnancy. Second, it should be a cephalic presentation. But in case of breech, we don't use Johnson's formula. Instead, we use something called as Rizanto's formula that we will discuss in breech class. So that is about clinical estimate of fetal weight. And what do you do at the level of palpation? So fundal height, correct the dextroversion with right hand. Fundal height, Johnson's formula, clinical estimate, clinically liker. Then you will do the grips. So fundal grip, lateral or umbilical grip, first pelvic grip, and second pelvic grip. So all the first three grips are seeing the patient's face, we have to elicit. And the second pelvic grip, we have to see the mother's legs, and we have to see whether we are able to, the hands are converging, it is an unengaged head, or the hands are diverging, it is a engaged head. So these grips, obviously as a postgraduate, you will be doing right in and out. So these grips have to be elicited. And percussion, we usually do not do in obstetric practice. Auscultation. So usually we will palpate the fetal spine, and at the level, usually in the spino-umbilical plane. So towards the fetal spine, anterior superior iliac spine of the mother and umbilicus midway, we will be able to auscultate the fetal heart rate. Why? Because at the level of the fetal spine, the fetal heart rate radiates to the left shoulder or the acromion, which is near. So that is why we will always be able to hear the FHR where the fetal spine is there. If it is a breech, usually FHR is heard at the level of umbilicus or above the level of umbilicus. But if it is a cephalic presentation, usually it is occurring at the spino-umbilical plane towards the fetal spine. So if the fetal spine is on the right side, it will be heard on the right spino-umbilical plane. If the fetus is left side, we will be hearing about left spino-umbilical plane. And then if she is complaining of leaking PV or bleeding PV or abnormal by discharge, we have to do a speculum examination, and we have to do a pervaginal examination if you think she's in labor, or if she's come with abruption or whatever, if she's in labor, or if she has any indications for speculum and vaginal examination, we have to do, and we have to comment about the Bishop score. So cervical position, consistency, dilatation, effacement, the station of the presenting part, the membranes, and the adequacy of the pelvis. So all this has to be written down in pervaginal examination. And finally, you have to come to a provisional diagnosis. For example, gravida 2 para 1 living one with 37 weeks period of gestation with cephalic presentation in latent phase of labor could be your provisional diagnosis if she's coming true labor pain. So later um, you will be able to do the necessary investigations of whatever is recommended according to your diagnosis, and you will be able to manage. So these are the important examination things which you have to consider. So today it was an elaborate class, but I have tried to cover most of the aspects of antenatal care. And so this was not a simply update. So it was I have referred different guidelines. So what all guidelines I have referred is the nice guidelines, which is nice antenatal guidelines, foxy guidelines, that is the binders update of foxy guidelines, I think 2016, the WHO guidelines again 2016, the ATA guidelines, that is American Thyroid Association guidelines of 2026, ACOG guidelines of mm, maternal immunization, again, it comes under 2016, and the Foxy Gestosis guidelines, which is our 2018 guidelines. So, all these I have referred along with books for antenatal care would be ideal books for antenatal care would be Williams. So, it has prenatal care is the heading of the chapter for all the recommended things during pregnancy. And what I have not covered is the theoretical aspects like minor ailments during pregnancy, like heartburn, nausea, vomiting, backache, and varicose veins, hemorrhoids. What are the minor ailments and what is the treatment? And the second important thing, what are the recommendations during pregnancy about rest, sleep, sexual intercourse, travel, air travel, long distance travel. So all these are some of the recommendations or recommendations of smoking, alcohol. All these I have not told because all these are theoretical aspects which you can study. And even Datta, at least you have to read three chapters. That is, one is antenatal care, diagnosis of pregnancy, and fetus in utero to understand all the concepts and diagnosis during pregnancy and the basic antenatal care which you have to follow during pregnancy. So these are the very important must know things as a postgraduate, which is very much important for you to understand for your exams and for your practice after post graduation. I hope you've all understood the concepts well. And if you have any doubts, you can message me personally. Most of you have my number, or I will put a poll or response question on the group. You can respond to that with any queries and doubts. I will be happy to answer. So this was a free class as a part of my Gynae Wizard short course. So if you want to enroll into this course, uh, you can email me to gynewizard@gmail.com. So the course comprises of 24 cases of both obstetrics and gynecology. So as today I have discussed the antenatal case discussion, all other classes also will be covered as a part of short course. So you can email me if you're interested to gynewizard@gmail.com your details. So I will be able to share you the brochure and the subscription methods. So I hope you've all learned and enjoyed thoroughly. And if any doubts, you can ask me. Now, I will open the meeting to mute yourself and answer. So if you want to ask any questions or any doubts, you can mute yourself and you can ask me. Any doubts? Okay, I take it as a no. If you want to ask me personally, you're all welcome. So I will post a response question on the group. So you can respond to it with all your queries, doubts, and your feedback. So your feedback is very valuable for me. So it will help me to improve on my subsequent classes. And if I'm too fast, this video will be available on free on YouTube. You can watch for better understanding. Thank you all. Thank you for joining today. Have a good night. Happy learning.